Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We are currently in our renal modules and we will be running through some questions with you guys to help you on a journey to a 250. So here we have, which segment of the nephron is primarily affected in the patient's renal pathology? A 55-year-old man with a history of hypertension presents with complaints of increased frequency and urgency of urination. Urine analysis reveals proteinuria, hematuria, and elevated serum creatinine levels. Renal biopsy is performed and shows thickening of the glomerular basement membrane, mesangial expansion, and nodular glomerulosclerosis. Immunofluorescence microscopy reveals granular deposits of immunoglobulin G and complement C3 in a spike and dome pattern. Which segment of the nephron is primarily affected in this patient's renal pathology? Now, this is a straightforward and easy question. I have only put you for the uh, understanding or orientation about the anatomy of the nephron. So we have the options: proximal convoluted tubule, loop of Henle, DCT, collecting duct, or glomerulus. So as you all know the answer, the patient's renal pathology characterized by thickening of the glomerular basement membrane, mesangial expansion, nodular glomerulosclerosis, and a spike and dome pattern on immunofluorescence microscopy is indicative of diabetic nephropathy. And diabetic nephropathy, there is damage to the glomerulus, particularly the glomerular basement membrane. The other options are PCT. While the PCT can be affected in various renal disorders, the presented pathology is more likely of uh, glomerular involvement. Loop of Henle is not the primary site of diabetic nephropathy. DCT is not typically involved in diabetic nephropathy, and the same is the case in the collecting duct. So here we have the cut section of the kidney. So this right kidney section in several planes, exposing the parenchyma and the renal pelvis. So kidney is covered up by a fibrous capsule, and after that you have the cortex, and then you have the medulla. Okay, now this medulla contains the pyramids, and these all medulla join and form a renal papillae, and in between the two renal medulla we have the renal column of Bertin, and this is the base of the pyramid. Now these all renal papilla, they all drain up into the this major and minor calyces, right? Now these all major and minor calyces then join and form the renal pelvis, okay? And then this pelvis continue as the ureter. Now, this is a very important picture about the glomerulus, the macroscopic picture of the glomerulus. Now, this understanding you need to have to understand the various nephrotic and nephritic disorders and their pathological involvement, the histology, the electronic microscopy, or immunofluorescence sort of thing. Now, you need to be well oriented on this figure to know about the concept. So, parietal epithelial cell, okay. Now, after that, we have the endothelial cell. Okay, now endothelial cell may participate in the production of the glomerular basement membrane and the initial segment of the filtration barrier, and it is fenestrated. Okay, now these are the endothelial cell. Okay, now this lining is the endothelial cell, and in between the endothelial cells there are small gaps. Okay, now these are called the fenestrations. Now, after that comes the glomerular basement membrane. Okay, this is the microskeleton of the glomerulus and participates as the filtration barrier. Now, after that comes the visceral cell with podocyte. Okay, now these also participates in the glomerular basement membrane, and these have the intercellular junctions, and are the final filtration barrier. So what are the filtration barrier? So by time now we have the endothelial cells, the glomerular basement membrane, and the visceral epithelial cell with podocytes. Now, the mesangial cells are contractile, produces matrix and phagocytes. So the cells between the two glomerular uh, cups are called the mesangial cell, and these contain the mesangial matrix. These are the supporting framework for mesangial cells and peripheral glomerular basement membrane. So in this figure, you need to understand that the glomerular basement membrane or the filtration barrier is formed up by the endothelial cell, which has fenestrations, glomerular basement membrane, and visceral epithelial cell with podocytes. Now, again, we have here the afferent arteriole, the juxtaglomerular cells, JG cells, the macula densa cells, the DCT. We have the endothelial lining in the arteriole and arterioles, And then we have the Bowman capsule, okay? So Bowman capsule has the parietal layer, and the visceral layer is by the podocytes, as we have discussed. So glomerular filtration barrier is responsible for the filtration of plasma according to the size and charge selectivity. It is composed of fenestrated capillary endothelium, basement membrane with type 4 collagen chains and heparan sulfate, and visceral epithelial cells consisting of podocyte food processes. The charge barrier is the glomerular filtration barrier, which contains the negative charge glycoproteins that prevent the entry of negative charge molecules. The size barrier is the fenestrate capillary endothelium and prevents the entry of more than 100 nanometer of molecules per blood cells. Podocyte food processes interposed with glomerular basement membrane, and it contains a slit diaphragm which prevents the entry of molecules more than 40 to 50 nanometer. Now, again, we have the nephron as a whole here. This is the glomerulus. We have the proximally convoluted tubule. Okay, as you can see the convolutions here, which is proximal, the descending limb, and then we have the nephron loop of Henle, and then we have the ascending limb of loop of Henle. Okay, so descending limb, loop, and ascending limb. And again, we have the distal convoluted tubule, which is again as convoluted as the PCT. And again, then after that, we have the collecting duct. So which segment of the nephron is primarily responsible for the observed electrolyte abnormalities? 45-year-old woman with a history of dehydration presents to the emergency department with symptoms of weakness, fatigue, and increased thirst. Lab tests reveal hyponatremia, hypokalemia. The patient is started on IV fluids and her symptoms improve. Further investigations show elevated levels of renin and aldosterone. Which segment of the nephron is primarily involved or responsible for the observed electrolyte abnormality in this patient? PCT, loop of Henle, DCT, collecting duct, or glomerulus. Or DCT, the patient's presentation with hyponatremia, hypokalemia, and elevated renin and aldosterone levels suggests a disorder known as hypovolemic hyponatremia with hyperaldosteronism. Now, in this condition, there is increased reabsorption of sodium and secretion of potassium in the DCT under the influence of aldosterone. PCT, the proximal convoluted tubule, is responsible for the majority of sodium and water reabsorption, but it is not the primary site of action for aldosterone. Loop of Henle is involved in the concentration and dilution of urine, but is not the primary site of aldosterone-mediated electrolyte transport. The collecting duct is responsible for the fine-tuning of the transport, fine-tuning the concentration of the urine, but it is not primarily site for aldosterone-mediated electrolyte transport. The glomerulus is primarily involved in the filtration of blood to form the glomerular filtrate. So again, we have the afferent arteriole, we have the efferent arteriole, we have the glomerulus, and then this is the Bowman's capsule. Okay. Now, first, there was filtration. Now, in filtration, there are no RBC or large protein normally. So what we filter? We filter sodium chloride, potassium, bicarbonate, H2O, glucose plus amino acid, creatinine, urea. These all happen in the PCT. Okay. Again, there is reabsorption that is occurring here. Okay. So these all happen in the glomerulus and a Bowman's capsule. Okay, now these all get filtered and enter the PCT. Now in the PCT, the reabsorption occurs. Now in the PCT, we reabsorb the 65% of sodium chloride and water, also potassium. We reabsorb 100% of glucose and amino acids. We reabsorb the 90% of bicarbonate. And after that, there is again separation of some other toxic metabolites like uric acid and organic acid. After that, the filtrate, these all go into the loop of Henle. In the loop of Henle, there is again reabsorption of water and sodium chloride. Okay. Now again, the urine is then concentrated because the water is being absorbed. And then in the thick ascending limb of loop of Henle, which is impermeable, okay, it actively releases sodium chloride. And again, in the DCT, there is action of aldosterone, which increases the water reabsorption. So nearly 5% of sodium chloride and water are reabsorbed, and the secretion of some amount of hydrogen and potassium. And then there comes the antidiuretic hormone, which acts on the collecting duct, which increases the water reabsorption. Okay, in the collecting duct again, also there is excretion of uh, creatinine and urea. Okay, so the water reabsorption occurs in the proximal part of the collecting duct, or the initial part of the collecting duct, and In the distal part, there is again some amount of water excretion and salt excretion. Okay, there's excess of sodium, or there is extent of potassium and H plus. So the thing is that first there is filtration occurring, and after that, we first excrete the following products, which again get reabsorbed. We again absorb water. We make the urine concentrated, and then we again absorb water, and again we leave some water back, and again we absorb some of the potassium and sodium changes that are occurring in the distal part of the collecting duct. So, which of the following factors is most likely involved in the filtration process within the renal corpuscle? A 30-year-old man with a history of hypertension undergoes a routine checkup, including a urine analysis. The urine analysis reveals proteinuria, and further investigation indicate impaired glomerular filtration. The glomerular filtration rate is found to be below the normal range. Which of the following process or factors is most likely involved in the filtration process within the renal corpuscle? Vasoconstriction of the afferent arteriole, increased hydrostatic pressure in the Bowman space, decreased oncotic pressure in the glomerular capillaries, constriction of the efferent arteriole, and expansion of the mesangial cell. So increased hydrostatic pressure in the Bowman space. The primary factor involved in the filtration process within the renal corpuscle is the hydrostatic pressure in the Bowman space. Now, this pressure is exerted by the fluid in the Bowman space and contributes to the movement of the water and solutes across the glomerular filtration barrier. Vasoconstriction of the efferent arteriole. So efferent arteriole constriction will decrease the glomerular hydrostatic pressure and reduce the filtration, because the blood cannot go from the efferent arteriole towards the glomerulus because the efferent arteriole is now constricted. There is decreased oncotic pressure in the glomerular capillaries. So oncotic pressure in the glomerular capillaries opposes the filtration, and a decrease will favor the filtration. A constriction of the efferent arterioles. So efferent arteriole constriction will increase glomerular hydrostatic pressure and enhance the filtration. An expansion of the mesangial cell. Mesangial cells provide the structural support to the glomerulus, but they are not directly involved in the filtration process. So again, which the following is a big defects in the filtration process is most likely responsible for this patient uh, presentation. So a 25-year-old woman presents with facial and periorbital edema, foamy urine, and elevated blood pressure. Urine analysis reveals the significant proteinuria, hypoalbuminemia, and lipiduria. Further investigations show elevated cholesterol levels. Renal biopsy reveals diffuse thickening of the glomerular basal membrane and effacement of podocyte food processes. So, which of the following defects in the filtration process is most likely responsible for this patient's presentation? Increased permeability of the glomerular capillaries, decreased hydrostatic pressure in the Bowman space, impaired reabsorption of proteins in the PCT, defective filtration barrier in the glomerulus, inadequate vasoconstriction of the afferent arteriole. So the patient's presentation with facial and periorbital edema, foamy urine, proteinuria, hypoalbuminemia, and lipiduria is indicative of a nephrotic syndrome. Now, the most common cause of nephrotic syndrome in adults is the focal segmental glomerulosclerosis. And in FSGS, there is a defect in the glomerular filtration barrier leading to the increased permeability of the glomerular capillaries, proteinuria, and subsequent hypoalbuminemia. The increased permeability of the glomerular capillaries is the correct mechanism in the nephrotic symptom, particularly in the FSGS. But the main mechanism here is the defective filtration barrier in the glomerulus. So again, we just go through this. So the filtration occurs, okay, filtration starts in the renal corpuscle, then in the PCT, there is reabsorption. Again, in the loop of Henle, there is solute concentration by the reabsorption of water. Again, in the DCT, we again reabsorb the water. And again, in the proximal convoluted tubule, we reabsorb. And in the distal convoluted tubule, we just have an exchange of hydrogen and potassium. Second, here we have, so when the blood is filtered in the glomerulus, sodium, potassium, and chloride and other substances are filtered in the tubule. Filtered substances then move through the tubule towards the collecting duct. Along the way, sodium, potassium, and chloride are reabsorbed from the tubule. Diuretics block this mechanism and at different sites along the tubule, and water tends to go where sodium goes. So blocking the reabsorption of sodium causes more fluid to remain in the tubule, where it is later eliminated as urine. Again, glomerulus blood is filtered. Proximal convoluted tubule will reabsorb. Again, sodium, potassium, and chloride are reabsorbed from the tubule. Okay, Now, this mechanism is inhibited by the loop diuretics, okay, which act on the loop of Henle. And again, in the DCT, it is acted upon by the thiazides, which again block the sodium chloride and sodium and chloride reabsorption from the tubule. The aldosterone antagonist block the aldosterone in the collecting duct, okay. And the sodium potassium pump causes the sodium to be reabsorbed from the tubule in excess for potassium. Then the ENaC blockers also, they just block the epithelial sodium channel, ENaC inhibitors, and these all causes the sodium to stay in the tubule. Now, since the sodium is in the tubule, the water will follow the sodium, so there is excretion of water. Now, this is the mechanism of action of diuretics. Thank you for watching. Keep studying hard.